You shouldn't clap yet, you haven't heard me talk.
We have great expectations.
Yeah. Let's see here. Okay, well, I'm Dr. Cuccaro. It's a pleasure to be here. I'm already really stressed out about this talk, and I'll tell you why. I'm a fast talker. I get very excited about the information that I'm delivering, and I've already been told, slow down. The other problem is I have a lot of information, and yet I only have about 15, 20 minutes to deliver it in, so I'm trying to figure out how do I slow down my talking, deliver the same amount of information in that time interval. So what I may do is skip some slides here. So what I'm going to be talking about is improving outcomes with pain by improving the understanding of pain, and this is really what I've been working on for the last year here. Just some background on me, like Dr. Nguyen said, I'm an anesthesiologist trained in Chicago. I did a fellowship in pain at the University of Michigan. And then I have a bunch of experience both in the military setting where we had a lot of complex pain, a lot of different patients. We had a huge catchment area, a lot of polytraumatic pain. And then I also practiced as basically a solo pain specialist locally here. And what I became very concerned about was the results that we're seeing. Now, results for me, and the reason this becomes relevant to the topic at hand, is if we are treating pain, just like you're treating any other disease system, we should getting people better. Or if we can't do that, not making them worse. That means if I'm going in and I did a lot of injections and procedures and things, we should be seeing people going back to work, functioning better, living better lives, using less medications. And what I saw repeatedly was that was not the case. So what I did is I went back to sort of the research and found a lot of information that I had not learned in my fellowship, which is shocking to me because, as I said, I am one of these pain specialists. I'm the one with the certifications and credentials there. And what I discovered was stuff that I did not know. So I took that and I went and developed this pain pilot to work with the local patient-centered primary homes. And the goals for this were to increase the understanding of pain and the mechanisms of treatment. So I'm actually teaching the clinicians about pain. And talking about pain in a different way, and hopefully so that we're all speaking the same language, because when it comes to language and how you get care, that becomes critically important. And also to increase the clinician comfort and confidence. There's a lot of frustration when we're seeing pain in treatments. A lot of frustration on both sides. Patients are saying, how come I'm not getting well? And physicians and nurse practitioners are saying, how come this isn't working? And what is happening? I'm not helping my patients that I want to do. And so the ultimate goal is if we can do this, then we can improve pain outcomes for our patients. Now, I'm just going to talk about the scope of the problem here because really to understand what the pilot is going for, we have to actually talk about pain. So when we look about pain, it's a common presenting symptom. You think about it, you don't go to your doctor, or nurse practitioner, or physician assistant when you're feeling well. You go because you feel something's wrong, and often that is something painful that you're experiencing. It's also the most common reason for disability. If you look at those people who are on Social Security disability, 3 of the top 5 are pain-related: back pain, neck pain, other musculoskeletal pain. We're spending massive amounts of money, $600+ billion in direct and indirect costs. And if you trust the Institutes of Medicine, they reported in 2011 that over 100 million Americans are experiencing chronic pain. Now, if you look at back pain, I'm just going to kind of skip over this, but it's most common reason for physician visits after looking at things like coughs, colds, and congestions. Everybody gets it, and that's both in our world as well as the developing world like sub-Saharan Africa, but we have different disability rates between the two. Now, what have we done for the treatment of pain? And I like to tell patients, and I even tell physicians and nurse practitioners this. When you go to your doctor's office, there's only 4 things that we can do to you directly. We can talk to you, sure, but there's only 4 things that we can actually do to you. We can look at you, we can cut you, we can poke you, and we can drug you. That is really it. And if you look at what we've done for pain, we've looked at you, we've poked you, we've cut you, and you've drugged you. But what have we done? What have we got for that? Well, actually, disability rates are increasing. They've tripled in places like North Carolina. The complication rates have increased dramatically. Healthcare costs have gone up exponentially, and we're not seeing any improvements in self-reports. But the big number to look at is if you go back in time and look at the year 2000, the US population was 282 million at that time. And it was estimated we had 45 to 50 million living with chronic pain. A large percentage, a large number of people. But then we go back to 2010, and the US population is only 309 million. But remember, the Institutes of Medicine said we had over 100 million people suffering from chronic pain. Now, if you can do the math quickly in your head, you'll see that's a 9.6% increase in the in the population. But that's a 122% increase in the prevalence rate of chronic pain. That's 10x the size of the population. and not explained by aging communities or anything else like that. So really the question comes down to why 122% increase in the prevalence rate of chronic pain at the end of what was known as the decade of pain control and research. Well, before we get into that, I'm going to ask you to play a little game with me, and this is called Pain or No Pain. And this is directly relevant to this talk. So I'm going to show you a picture here, and I want you to tell me whether this patient is experiencing pain. So if you look at that, not the best shot, but this is a steel-toed boot, and that's a 6-inch spike that this guy drove through his foot when he jumped off of a building. This was in Great Britain. When this happened, he hit the ground screaming. He was carried by the ambulance into the emergency department. He was inconsolable. They couldn't do anything with the boot. They had to give him this very strong painkiller known as fentanyl. It's 100 times more potent than morphine. And a very strong anxiolytic known as Versed. And when they did that and he finally calmed down, they could cut his boots off. And what they found was the spike went between his toes. So then the question becomes, pain or no pain? Pain, right? He said he had pain. No tissue damage, but he was experiencing pain. So much so that he got huge doses of medications that if he wasn't experiencing pain, he'd probably pass out. Can we say, we don't have a lot of time, unfortunately, I would other ways to talk about that. How about this patient? Now this is not a great picture either, but that is a nail that this guy drove through his thumb with a nail gun. Apparently this is super common. Pain or no pain? Pain. Minimal pain. I got this off of YouTube. This is a guy, there's a couple key things. He's done this before. This is very common for people using nail guns. He said, wow, I shot myself. He has his iPhone. He looks for Randy, his boss. In the rest of the video, they're trying to take a pair of pliers to pull this thing out of his thumb. Minimal pain. How about this one? Now, for those of you who don't, this is an x-ray, and what we see is a pretty bad-looking spine here. And for comparison, this is what we would look, this is a normal-looking x-ray of your low back here, okay? So normal sort of, no curvature, really nice looking. This one's got a big, old scoliotic curve, and all this white stuff is really kind of degeneration and lots of bone being built up on each other. So when we see a spine like that, we're looking at this image. Pain or no pain? No pain. This was given to me by one of the people in my program when they were talking to their patient. This is a 66-year-old lady. She has no back pain with a spine that looks like that. And I will also tell you, I've seen people with spines that look like this. They were gulping down morphine because they had horrendous amounts of pain. So then the question becomes, how can someone have a nail in their thumb but little pain, or a spike through their foot, or at least through the shoe, but severe pain, or a twisted spine but no pain? And really the answer to that is, what is pain? So luckily we have a great definition of pain. I will tell you, again, as a fellowship-trained pain specialist, this is a fantastic definition that I did not understand when I learned it many years ago. And that is that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. What this really comes down to is fundamentally pain is an experience. It has both a sensory phenomenon. You feel something in your body that attaches this emotional component to it, the meaning behind it, in order to create the experience of pain. So what we see that experience comes from is that sensory aspect, the feeling that tells us, hey, there's a sensation coming from somewhere in our body. Then we add to that this emotional context, the meaning behind it. What does that sensation mean to me? And with that, we finally add the last part, the thinking aspect, how much attention we're paying. Does this matter right now? Because there are some sensations that really don't matter right now. And what should I do next? And in this way, when you realize that pain has three components in order to create its experience, it's very similar to something else, fire. So how many people have seen this kind of diagram before? Right? When I first did this, I was like, I must have learned this in physics or chemistry, and then someone in the audience raised their hand, no, I learned this in Girl Scouts. Brilliant, absolutely. And why did we learn this in Girl Scouts or Cub Scouts or whatever? And why do they still teach this to firefighters today? Is because when you recognize that fire really is a process that requires three components in order to create fire, how you fight fire changes depending on what these components are. So when you take pain then, and we put it together and make a pain triangle, we see that we have a sensory aspect, like a fuel source. We have this cognitive, or the thinking part, the attention that we're playing to, which provides heat. And then the meaning behind that sensation, which provides the oxygen, in order to create an experience of pain. And you have to have all three. So how this builds up and puts together that sensory aspect, that fuel here, we kind of talk about that typically as being involved with the nerves in your body and also the spinal cord, how this information is coming up from your body. As such, we call this bottom-up information, again, from the body to the brain itself. Now we have the emotional context. This is the meaning behind the sensation. We're going to go over some examples. When you have the same sensation but dramatically different experience from that, and it has to do with the meaning, and it's heavily influenced by what we believe that sensation to mean and what we expect is going to happen from the result of that feeling. And then lastly, we have that cognitive, the heat aspect, is how much attention we're giving to it, as well as the context. What else is happening? Who else is around us? What's the environment that we're in? But what gets mistaken, and what I have to remind physicians when I'm working with them, is that these two elements here, that cognitive and the emotive element, also have an influence on how that sensation comes up from the body. So nerve transmission comes up to your brain, and we can either open up the pipes and say, give me more information, or we can shut it down, and that has to do with this thing up here. Now, important, though, to distinguish is what is this stuff? That's wood, and specifically it's firewood. And we can say that's the source of fire, but nobody takes a piece of wood and holds it in their hands and thinks they're going to get burnt, or puts a piece of wood in their fireplace and thinks, oh, I'm going to heat my house with this. Now, in the same way, if we take our pain triangle and we just take out this sensation aspect, and specifically when we take structure, we start talking about structures being pain coming from the structure, that is in some ways just like this. And what we're trying to pull from that is describe sensation is saying the sensation by itself is really just nerve stimulation coming from the body. That's it. This means it's also anesthesia independent, meaning when I put you to sleep under general anesthesia and the surgeon cuts you, there is still nerve information coming from your body up to your brain. There's just no brain there to process it. And as such, we really call this body-based. The sensation is really just information coming up from the body. And so it really is just firewood when we're looking at pain. Now, pain's dramatically different, though. Pain, we have both the attention and the meaning given to that sensation from the body. As such, this means it's anesthesia dependent. If I put your brain to sleep, you cannot experience pain because there's nothing there to process that information. As such, we know that pain is entirely brain-based. It takes an awake and alert brain in order to create an experience of pain, and that's your fire. 3 elements to create. Now, can you have sensation without pain or pain without body damage? And you guys know the answer to this because we already did some pictures of it. Because the answer is yes, obviously. And you have sensation without pain. If we have something, even severe damage to the body without pain, when does that occur? In things like life or death events. So I was a military physician. How could people be in these war zones, have limbs blown off their body or get shot, yet carry their buddy out, not even realizing it? And it has to do with the way the brain processes. Remember, the brain can shut down information from the body or facilitate that, or have more of it. And in a scenario when you think you're going to die, that experience, that sensation becomes a distraction to you. And your body goes, let's turn that off. We don't need to know this until we are safe. And other ones, distraction. If you are in a safe environment, if you are comfortable or around people that you love and respect, and you have something occur to your body, you may not pay any attention to it at all. So an example I give for that is if you're walking through the woods and you love to hike, and you're with your best friend and you're chatting and you push through some bushes, and all of a sudden you keep walking down the road and your friend looks over and goes, why are you bleeding all over your hand? But you didn't even notice it. You were distracted. Tissue damage, but you didn't experience any pain from that. And other ones, if you believe something is harmless, lo and behold, you don't experience pain from much. So there was a study where they took hot metal bars and they put them against people's necks. And they said, hey, we're going to put this hot metal bar against your neck. I want you to tell us when you feel it, when it gets uncomfortable, and when you can't stand it anymore, so we can take it off. And they did that to everybody's necks. Then they took a cold metal bar, and they said, we're going to take a cold metal bar, we're going to put it against your necks, and we want to know the same things. When you feel it, when it gets uncomfortable, and when you want us to take it off. And they did that. And lo and behold, people who had hot metal bars on their necks, it felt painful when they wanted them off very fast. Here's the kicker, though. Those bars were exactly the same. They were just very cold. What they just manipulated was the meaning behind it, because culturally we understand and expect that if something is hot, that is more likely to cause damage. And it's also heavily influenced by what we learn in previous experiences. So if you've been in a scenario where you had horrible damage occur and then you get in the same kind of body position, you're more likely to experience pain in that regard. Now, when you have pain without damage, similar. If we put you in a highly threatening environment, lo and behold, your body's looking for that, takes that information and creates an experience of pain. It's a survival mechanism. Belief of harm. So just like we had hot metal bars or cold metal bars, right? So if you thought it was causing harm, lo and behold, your perception and your experience of pain went up. Or if you expect harm to occur. So if I tell you that this is going to be extraordinarily painful and I'm going to damage you, lo and behold, you experience more pain from that. And this is also inflected by learning and previous experience, what we've told you, what you've learned in past experiences. The important thing, though, to know is that sensation alone is not the same thing as pain, just like firewood doesn't equal fire. And this becomes important because the body's sending sensations constantly up to your brain. And what we know now is those normal sensations, sensations that aren't even associated with potential tissue damage, can be taken in certain scenarios and be processed into an experience of pain. Now, the reason all this matters, and hopefully I'm not spending too much time on this, is if you look at the treatments, again, when we look at what we've done for pain, increased MRIs, increased procedures, I stuck a lot of needles into people, the surgeries that we do, and a lot of the drugs that we prescribe, all of those are essentially directed down here. We inject structures, we do surgeries on structures. A lot of the drugs are because we believe that there is some sort of nociceptive information coming from a structure. And yet, when we look at the risk factors, when we look at what makes pain worse, or the people who are more likely to have long, prolonged pain, the risk factors are here, in here, but not here. Not related to the structure itself. Yet, where are all our treatments focused? And in worst cases, the treatments that we do down here can actually make those worse. So what we look at, what we did and what we got, we understand we increased MRIs, procedures, and surgeries, and we increased all these opioids prescriptions. And what we find is we increased disability rates, increased complication rates, increased healthcare costs, and increased the prevalence of pain. So really the goal of this pilot, what we've been doing locally and what we're trying to do, and what you may hear if you're seeing a local provider, is we're talking about pain so that we can understand pain and we can understand the risk factors involved and we can understand the treatments so we can improve the outcomes for pain for our patients. And if you have any questions, save them to the end because I know we don't have a lot of time here, but I have more information there. Nellyda?
Thank you so much, Kevin. And I just want to say I feel somewhat intimidated by following up his wonderful presentation, but I have to say, as a primary care provider who does a lot of pain management here in primary care, having Kevin come speak to us and teach us all he knows about pain was like somebody just scattering a bunch of gold nuggets on the floor, and you try to pick them up as fast as you can because they're so valuable, but he has so much information, and you can tell just by how quickly he talks that it's hard to get it all in one dose. We were lucky enough to have 3 hour-long interactive sessions with Kevin where he got to go in depth a little bit more about each, 5, 6? Was it 6? Boy, okay. Well, apparently there were 6. That's true. We had a bunch of follow-ups. So initially we had 3 and then we had some follow-ups. So we had a lot of information to try to download into our brains. He's been doing this for many years. We all just kind of were introduced to this new paradigm about how to treat pain this year. So I apologize for my PowerPoint. I'm not the best with technology. So I just did this to kind of cue myself as to what I wanted to talk to you about tonight. Basically, I think for me, the part that really I wanted to really focus on was how I was trained as a nurse practitioner. And it actually started for me in nursing school. So I went to nursing school about 11 years ago, and I was trained in the paradigm that pain is the 5th vital sign, pain is what the patient says it is, and you treat it until it's gone, or you treat it until the patient says it's acceptable. And that was really coming from sort of this firewood thing that Kevin was talking about, really looking at the pain structures and sort of focusing on what this was happening to the body and not what the experience of pain was. And going into nurse practitioner school, we basically got very little training in chronic pain management. Essentially, we were taught that you just take what you know about acute pain and do it for a long time, maybe forever. And that was, truthfully, that was kind of the extent, and it's embarrassing to admit that. I didn't realize how much chronic pain management I would be doing in primary care. And so I actually today, right before I came over here, I went around my office practice and spoke with my physician colleagues and my mid-level provider colleagues, and I asked them, what kind of training did you get in your medicine programs and your mid-level provider programs about how to treat chronic pain? And these were the answers that I got. 0 was literally one quote, none was another. And another physician said, you know, during my residency and in most of my career, and this was a physician who practiced in California for many years, it was the responsibility of neurologists, oncologists, palliative care specialists, pain management specialists. So, and I just wanted to kind of point out that primary care, though it's a huge domain for pain management, wasn't, I suppose in my training, it just was kind of overlooked. It's sad to say. So, and there are all these risks that come with traditional pain management practices, i.e. opioid treatment. And we all knew about all these problems, but we were never taught a rational way to reconcile all these risks and what we know with how to actually manage this in practice on a day-to-day basis. And so fast forward into practice, I'm a new nurse practitioner. In fact, my year anniversary was just about a couple weeks ago. And fresh out of school, I adopted a panel of patients here in the community who had been seen for many years by other physicians and other mid-level providers. And a good number of these patients, possibly a quarter of the patients, if not a third, were receiving quite high doses of opioids for their chronic pain. And I adopted these patient panels without realizing that I was, this was a new practice for me, a new career choice for me, and suddenly I had this responsibility to refill high doses of opioids. And these patients had lots of risk factors for having dangerous levels of medicine in their body. They were taking benzodiazepines, so things like Valium. A lot of them admitted to using marijuana and drinking heavily. And all I could think about was, oh my gosh, I'm going to be the next, Michael Jackson doctor. And it's really scary to start a practice like that and not know how to reconcile this sort of patient satisfaction and these expectations that had been built with what I knew to be safe, which was to prescribe less. And all around the same time that I was starting, the new CDC guidelines were coming out saying that we needed to rethink how we treated chronic pain. And, but again, it's sort of like know that there's something better, but we didn't really know what it was, and I didn't have any role models to tell me what that was. And all of a sudden, here comes Dr. Cuccaro, and it was perfect. It was a breath of fresh air for me. So I first had the pleasure of learning about Dr. Cuccaro's approach when he spoke about a year ago. Samaritan rolled out kind of our new guidelines for how to manage chronic pain in primary care. And he just, kind of the same way he presented to you, he just really started hitting the bullet points that we've been increasing prescriptions, and at the same time, reports of pain are going up, not down, and opioid-related deaths are also going up. And again, I mean, there's a lot more data there, but those things really resonated with me. And it was the first time I had ever actually heard somebody say, this is bad and we need to do something different. And so then we were lucky enough, the clinic that I work in, which is right across the street here in internal medicine, we were lucky enough to be invited to do a pain pilot with Kevin. And basically, I could go on, and I won't, because I know we have a lot, or limited time, and there's a lot that we need to cover. But the essence of this was, again, sort of the first time someone was saying, we need to do some practice changes, and here's how. And for me, hearing that there's kind of a difference between the body part of pain and the brain processing pain really helped me go into the office and start talking to my patients on a more experiential level, and helping patients understand that this back pain that they have, as long as I can rule out the red flags like cancer or infection, isn't going to be worse if they don't have their medicine, or it's not going to get worse if they go out and exercise. And just for me, being able to take what I kind of knew on a cognitive level and apply it in practice, that was facilitated by these sessions that we had with Kevin. So I won't go into this. We talked a little bit about, he talked about nociception, which is sort of the tissue damage part. But for me, that being able to talk to patients about their experience really helped me connect with people on a more empathic level. It's really hard to look at someone and say, there's nothing I can do to you. And before, I didn't really have that language. I just felt like I was scrambling, trying to fill a gap that I felt like we were kind of expected to do as providers. So it was nice for me to be able to say, you know, this is an experience, it's real, it's uncomfortable for you, and let's see if we can help you manage the experience that you're having, and not making any promises about taking the pain away. So I'm not going to go into the active and passive coping. This is a whole topic. But one thing I do want to point out is that something that was really important is this idea of tapering patients off their opioids. This is something that, again, we were kind of encouraged to do, but we had never really been told how or when or why, and Kevin didn't go into this in his talk, but he gave us great, really, really helpful information about sort of appropriate times to taper someone immediately, patients who are safe to kind of slowly taper, and just having that information makes something that was seemingly kind of the domain of a pain specialist before actually approachable, and something that I have been successful doing in primary care, and that's something I never thought that I would be able to do, and I'm so happy to tell you that I actually have taken quite a number of patients. I hate to say I have taken them off opioids. I've encouraged them to stop, and they've done so willingly, and every single one has reported good outcomes, better quality of life, and no increase in their pain. So that's been wonderful. And so, yeah, I mean, the short version of this is just the impact for me for this was just really for the first time in my whole career, even as a nurse and definitely as a nurse practitioner, I feel confident now that I can go into a room and connect with my patients on an empathic level and say, I know that this experience you're having is real and it's affecting you, but I don't want to harm you, and I know that, you know, these drugs can be harmful and they may not ever make you better, so let's talk about ways we can do this in a safer way. And so far, so good. I haven't actually started anyone on opioids since I did the pain pilot, and yeah. So I'm just very thankful.